Treatment of PCOS is a culmination of all the pathophysiological factors which you have learned till now. So it should be easy, to be honest. So the treatment lies in treating three things. One is the hyperandrogenism, second is the cycle irregularity, and third is the insulin resistance. So which means you are going to make the menstrual cycles regular. So which means you have to treat the menstrual irregularity. And second one is the treatment of hyperandrogenism. And third one is the treatment of insulin resistance, which means you are going to reduce the hyperinsulinemia. So these are the cornerstones of treatment of this PCOS. So how will you treat the menstrual irregularity? So which means you have to regularize the cycles. How can you do that? Regularization of the cycles can be done by two principles. One, by giving either a estrogen progesterone combination pill, which is the most commonly preferred one, or you can give a progesterone only pill, which is less preferred compared to estrogen progesterone combination. The combination is the one that is most commonly used and it's the preferred therapy. So remember, most of the therapies can have an overlapping picture. For example, estrogen progesterone combination can not only treat this cycle irregularity, they can also treat this hyperandrogenism as well. That's why I put a lot of overlaps among them, which you have to understand. So how the estrogen progesterone combination works? The estrogen progesterone combination works by different mechanisms. For example, this estrogen component in the estrogen progesterone combination is going to increase the SHBG. We know that estrogen is known to increase the sex hormone binding globulin, which can reduce the amount of free androgens, thereby improving symptoms of both cycle irregularity as well as your hyperandrogenic features. And this progesterone combination in the estrogen progesterone combination pill is going to inhibit the LH, because progesterone can give negative feedback to pituitary by reducing LH release. And you know, PCOS is going to produce anovulation, and anovulation itself, because of low progesterone, can produce more and more LH, causing more and more hyperandrogenism and worsening anovulation, and it's a vicious cycle. So progesterone can break this by in suppressing the LH release, which will reduce the androgen production from the theca cells. So this is how the estrogen progesterone combination works. Apart from this, it can make the cycle regular also if you give them in a correct way. So details of how to give in which population is beyond the scope of the discussion, but still if you give in a correct way, in a proper withdrawal, you can regularize the cycles very nicely. So what are the side effects? So side effects of estrogen progesterone combination usually comes from estrogen as well as the progesterone component in the pill. So estrogen component is responsible for increased risk of thrombosis. Remember, 4 times increased risk of thrombosis there compared to the general population. And second is increased nausea and increased fluid retention and weight gain. So this is usually due to the progesterone component, and this increased risk of thrombosis is usually due to the estrogen component. So these are some of the side effects of this estrogen progesterone combination pill. But in general, what are the estrogen that you are going to use and what are the progesterone that you are going to use? Estrogen that we generally prefer is ethinyl estradiol, very commonly used, even though some areas do use conjugate estrogen. We currently don't use conjugate estrogen in our practice. It's gone beyond our practice. Now we are using only this ethinyl estradiol. Along with that, the progesterone that you are going to choose is what the key is. What the progesterone that you are going to use? There are multiple progesterone options available. For example, you have drospirenone. Drospirenone has some advantages as well as disadvantages. The most important advantage is a natural anti-androgen, which can be combating this hyperandrogenic features, and it is also going to have some disadvantages, like it's having a little high risk of producing thrombosis, and it's also a natural anti-mineralocorticoid, which is not so good. Clear? So these are some of the advantages as well as disadvantages of drospirenone. But you have combination. For example, the combination of this ethinyl estradiol along with drospirenone, the combination has a very common name called as Yas or Yasmin, which is a brand name very commonly used in practice. And second is the even more commonly used progestin, that is called cyproterone acetate. Cyproterone is such a commonly used compound in clinical practice along with ethinyl estradiol. It is a natural anti-androgen, that is a big advantage, and the combination of this ethinyl estradiol with cyproterone is what we famously call as DIAN. Then we have other compounds like norgestimate, we have ethanoidiol, dictate, then we also have desogestrel. Clear? So all these three compounds are natural mild androgens, not significant androgens. They are mild androgens, but one student might think like since they are mild androgens, they are less preferred. No, it's not like that. Remember the fact that use any progestin doesn't matter. Your outcome is the same. Even though anti-androgens, theoretically, they might provide a marginal benefit compared to that of that other three progestins, but trial-wise, it's been clearly proven that usage of any progestin is not associated with any significant benefit. So you can prefer any androgens, any progestins, not a problem. Even you can prefer these mild androgens also, but they don't have any significant adverse outcome. So remember, this combination of this desogestrel along with ethylene estradiol is also very common in India. The brand name we call it as Novolon. So these are some of the combination names I have told you, but no need to remember for your exams, to be honest. So what are the progesterone-only combinations? There are some progesterone-only combinations available, progesterone-only pills available. So what are the indications? In general, we don't prefer. So you can prefer this progesterone-only pills in patients who are having predominant anovulation. Only predominant anovulation with not much hyperandrogenic features, then you can prefer progesterone-only pill. And second one is the patients who are having contraindications to combination pills. So if those who are having contraindication to estrogen-progesterone combination, then in those patients you can try progesterone-only pills. So what are the side effects of progesterone-only pill? It is little bit more competitor of estrogen-progesterone combination because progesterone-only pills cause more fluid retention and weight gain compared to estrogen-progesterone combination because the dose here needed of progesterone is little bit high. Then they can produce breast tenderness, which is an effect of progesterone, breast engorgement and tenderness. They can produce severe nausea, and that is the reason why whether you give progesterone-only pill or estrogen-progesterone combination, it has to be taken in the night most commonly because that's the best time to take because to avoid this nausea. And at the same time, progesterone itself can cause more and more acne, and they can cause a lot of mood changes and mood swings. So these are some of the complications of progesterone, side effects of progesterone-only pill. So we'll be discussing if there is time this hormone replacement therapy and regards to progesterone more when we are discussing about menopause, but in the bonus section, not now. So these are some of the side effects of progesterone-only pills. But what are the overall efficacy, effect of this estrogen-progesterone combination or progesterone-only pill? Remember menstrual regularity. Menstrual regularity, especially with estrogen-progesterone combination, is achieved in almost 100%, and to achieve this menstrual regularity, it takes a minimum of 2 months. Almost all patients will achieve this menstrual regularity. So that is the final effect. Second effect of this estrogen-progesterone pill is the reduction of hyperandrogenic features like the FGS scores. The Ferriman-Galway score will reduce by approximately 30%. And this is very important to understand. This reduction by 30% is fine, but this reduction in the estrogen takes 6 to 12 months to produce an effect. So don't be hasty when you start any therapy for hirsutism. Wait for 6 to 12 months because the hair cycle is in such a way it takes some time for the old hair to be shed and new hair to come. It takes 6 to 12 months for the reduction in hirsutism due to any therapy, not only due to estrogen-progesterone combination. Similarly, they can reduce acne by approximately 50%. These are some of the data, these are some of the effects of this estrogen-progesterone combination pill which are very, very commonly used in these conditions. Next, usage of GnRH analogs. GnRH analogs to regularize the cycles is very rare. You don't do generally GnRH analogs, but in extreme cases where there is persistent hyperandrogenism and if estrogen-progesterone pills are not working at all, then you can try this GnRH analogs. GnRH analogs, what you're going to give is triptorelin, and you can even try leuprolide. So what these drugs do, these drugs completely shut down the pituitary and the hypothalamus. These drugs completely shut down pituitary hypothalamic circuit, which means there will be literally no production of FSH and no production of LH. So which means they will completely reduce the hyperandrogenism. They are very, very effective for reducing hyperandrogenism, but they themselves will cause anovulation. They reduce androgen production because there is no LH. If there is no LH, you cannot produce androgens because of complete shutdown of the pituitary by giving continuous GnRH, but they themselves can cause anovulation because there is no FSH. If there is no FSH, you cannot produce ovulation. So there absolutely no ovulation will be there. And one of the important side effect is the fact if there is no FSH, your estrogen production will also drop considerably. If there is no estrogen production, you will result in osteoporosis if you use this for a long time. So to avoid this anovulation and this osteoporosis, you need a add-on therapy with estrogen. You need add-on therapy with estrogen or a estrogen-progesterone combination. So this estrogen add-on will reduce osteoporosis. If you give a estrogen-progesterone add-on along with GnRH analogs, it can avoid this menstrual irregularity also. But the patient will be anovulatory only. They cannot achieve ovulation in the presence of this GnRH analogs. Is there any role of steroids like hydrocortisone? Yes, but you might be asking, sir, are you kidding? Steroids in a PCOS patient? Yes. How? Because there are estimated 10 to 20% of case of PCOS where they have a functional hyperandrogenism due to increased adrenal activity. Hyperandrogenism. This is also referred to as functional hyperadrenalism, and that is estimated to happen in 10 to 20% of the cases. Remember, this has to be considered only as a last resort where you can suspect this in a patient who's having a lean PCOS, not an obese PCOS. And at the same time, these patients who are having failure to respond to OCPs even after 8 to 12 weeks. Failure to respond to OCPs even after 8 to 12 weeks, your estrogen-progesterone combination. So these patients can be suspected to have this functional hyperandrogenism. But remember, the first thing you have to think whenever there is a failure to respond to these OCPs is the fact that these girls may be having some other grave diagnosis like tumors or maybe a congenital adrenal hyperplasia. That is the reason why PCOS itself is a diagnosis of exclusion. You should always rule out the other cause of hyperandrogenism, then only you have to come to PCOS. Suppose if you have not ruled out other cause of hyperandrogenism and the patient does not respond to OCPs after 8 to 12 weeks, at least at that point you should try and rule out other cause of hyperandrogenism. Otherwise, you will be missing out grave conditions like adrenal or ovarian tumor. So be very careful. So functional hyperandrogenism. So how will you treat this? You are going to start with hydrocortisone, where many people might respond with a standard dose of 10 to 15 milligram per meter square per day. In adults, usually we start with 15 to 25 milligram given in 2 to 3 divided doses of details of which we have seen already. So this is what we refer to as a functional hyperandrogenism due to hyperadrenalism, which happens in 10 to 20% of the girls with PCOS, where you have ruled out all the other causes of hyperandrogenism. Now we are sure it's a PCOS. In those patients, hydrocortisone might be beneficial and helpful. So how we are going to treat this hyperandrogenism? And the most important clinical problem associated with the hyperandrogenism is hirsutism. And a lot of girls do get anxious and depressed because of this hyperandrogenism, and you have to address this fact. So for that, you have to know how testosterone causes the hair growth. So for example, testosterone becomes dihydrotestosterone with the help of this 5-alpha reductase type 2 isoform. And this dihydrotestosterone acts on androgen receptors. This androgen receptors is the one that is responsible for the production of this terminal hair, sexually dependent hair. And you can have multiple treatment options for this. One is reducing the levels of testosterone itself. Your estrogen-progesterone combination itself reduces the levels of testosterone by multiple mechanisms. It reduces the levels of free testosterone by reducing sex hormone binding globulin estrogen effect, and progesterone itself by LH mechanism, they can reduce the androgen production from the theca cells. So then you can inhibit the dihydrotestosterone production by inhibiting 5-alpha reductase enzyme by giving a drug called finasteride, very, very commonly used drug, and this is one of the only drugs that has very, very little side effects compared to the other drugs. And you can also block the androgen receptor. Androgen receptor can be blocked by multiple drugs. Very important drug is the spironolactone. But spironolactone is not preferred nowadays because of its anti-mineralocorticoid effect, producing diuretic effect as well as hyperkalemia, which you don't want in these girls. And at the same time, there are other drugs like flutamide. Flutamide is not currently preferred that much because of its heterotoxic potential, even though some drug combinations do have flutamide. And very commonly, if you want to be even more conservative, you can prefer cyproterone acetate because it is a natural progestin which can be combined with the estrogen-progesterone combination pill. It's an anti-androgen as well. But the problem is it produces vomiting and progestational side effects. Apart from this, you have some local measures as well which can be done, like photoepilation. These are sometimes can cause scars and pigmentation. So light-skinned individuals has to be a little bit careful regarding this photoepilation and electrolysis techniques. Or you can use topical drugs like ofloronectin, This oflornithine is a ornithine decarboxylase inhibitor. And sorry for the spelling, ornithine decarboxylase inhibitor. So which is important for the cell cycle of the hair. So whenever you give ornithine decarboxylase inhibitor like oflornithine, the hair cell cycle will be blocked so that the hair will be shed and your hirsutism will be resolved. It's a local therapy, never be given as a systemic therapy for sure. But please do understand the fact that any treatment you give for hirsutism generally takes 6 to 12 months to be effective, and don't be hasty and keep changing the treatment and wait for 6 to 12 months for the improvement to happen. And the insulin resistance as such, the most important things that we do is weight reduction, or you can prefer some drugs. So weight reduction is the key. Minimum at least 10% of weight should be reduced in any conditions that are related to obesity. So this can be achieved by lifestyle measures, by like regular exercise, intensive workout and all these things, but it's very difficult to achieve in a patient. You can start with certain drugs like metformin, which can reduce weight to a great extent, or you can start certain drugs like GLP-1 analogs, which are also going to reduce weight. It's a drug that causes gastroparesis, causes early satiety. By central mechanism, it can cause reduced appetite as well. So it produces a good weight reduction. Or you can try even a bariatric surgery, but it has very, very specific and special indications, which we'll be discussing later on in the obesity chapter. So these are the components of weight reduction. Drugs as such that reduce insulin resistance, most important drug is the metformin. We know that it reduces weight, at the same time it reduces peripheral insulin resistance as well. And second thing, probably another drug called mya-inositol. It's very famous among the diabetologists, but it's the experimental evidences are there in the rats, but very poor evidence is there in the clinical trials. Whether it translates into clinical practice or not, we don't know, but even though it's a very popular drug among the diabetics. So these are the ways to reduce the insulin resistance. Fine. So let us summarize the different treatment options. For example, what are the drugs that treat this menstrual irregularity? What are the drugs that treat this hirsutism? What are the drugs that treat the insulin resistance? Let us see in detail. So now metformin, the effect on menstrual irregularity is variable, even though very commonly preferred drug. And even in our practice, it's very variable response. Some girls do get a good response, some ladies don't get a response. So hirsutism, it does not treat for sure. Insulin resistance, yes, sure shot, it treats insulin resistance for sure. And estrogen progesterone combination pills, menstrual irregularity is a sure shot. You will achieve with estrogen progesterone combination, even though poor responsiveness should alert towards a wrong diagnosis or probable functional hyperandrogenism. Hirsutism, yes, it treats. I told you FGS scores reduces by 30%. And insulin resistance, no, it doesn't treat. And progesterone only pills, menstrual irregularity, yes, they do treat hirsutism. They don't treat. In fact, they can produce more acne. And insulin resistance, they do not treat. And GnRH analogs, menstrual irregularity, yes, they do treat. And hirsutism, yes, they do treat. Remember, the patient might become amenorrheic, but it treats the irregularity. That's what I'm talking about, GnRH analogs. And hirsutism, yes, it does treat, because complete the hypothalamic pituitary axis will be shut down, and you will be having no production of testosterone from the theca cells, androgens from the theca cells. And insulin resistance, no, it doesn't treat, obviously. It's a well-known fact. And anti-androgens, if you start them alone, they can even worsen the menstrual irregularity. So you have to give, along with the estrogen progesterone combination usually. Hirsutism, yes, they really treat. Insulin resistance, they don't treat. So these are the treatment options are available, and these are the summary of different treatment options that you have. Having known all these things, the most important thing finally, as I promised, which I'm going to discuss, is on the secondary amenorrhea, because this is a very important topic for your exams. Many questions are there in secondary amenorrhea. I'm not going to discuss the entire details on secondary amenorrhea, but just on the outlines on how to diagnose and probably treat a secondary amenorrhea through a flowchart. So remember, when you call as secondary amenorrhea, what is the definition of a secondary amenorrhea? Remember, a girl who has already spontaneously experienced a menstrual cycle, which means a girl who has already spontaneously experienced a menstrual cycle now is not menstruating for at least more than 3 months or 90 days. So this is what we refer to as a secondary amenorrhea. One of the most common and important causes is PCOS. Clear? Now, as a part of routine evaluation, we'll be doing UPT first, because anyone can be pregnant in the reproductive age group. So first, always do a UPT. If UPT is positive, I'll be thinking the patient is pregnant. That is the cause of amenorrhea. If UPT is negative, then I'll be thinking about other causes. In this, one of the first evaluations I'll be doing is the progesterone challenge, which is a very easy and cost-effective test for testing the presence of estrogens and progesterones in the body. So suppose along with this progesterone challenge, we'll be doing a soup of investigations. So what are the soup of investigations that you're trying to provide to the patient in the form of free T4 and TSH, because hypothyroidism is one of the important causes of secondary amenorrhea. At the same time, I'll be doing prolactin, a cheap and inexpensive test, one of the important tests that we do for evaluating secondary amenorrhea. And next is total testosterone. In selected patients who are having hyperandrogenism, we can do, or even probably in selected populations, you can do a 17-oxy progesterone test also. But this is generally not done as a part of routine evaluation in practice. We do only these 3 tests. Total testosterone is also based on whether or not the patient is having hyperandrogenic features. So now, what is the base of progesterone challenge? Remember, progesterone challenge reports can be compiled as either it's a positive progesterone challenge or a negative progesterone challenge. So when you tell it's a positive or when you tell it's a negative, for that you have to understand the base of this progesterone challenge. The drugs that we usually give for progesterone challenge is medroxyprogesterone acetate, which is given in the dose of 10 milligram, and or you can give a norethistron in the dose of 5 milligram, or you can give micronized progesterone in a dose of 400 milligram. So usually these drugs are given for a duration of 7 to 10 days in general, and you are going to stop these drugs after this 7 to 10 days. So which means you have to produce withdrawal bleeding when you stop these drugs. Clear? Withdrawal bleeding. So remember, withdrawal bleeding will happen physiologically only if the uterus is already primed with estrogen. Estrogen has already primed the uterus. Now progesterones will convert this proliferated endometrium or a primed endometrium into a secreted endometrium. Now you stop the progesterone, you will result in withdrawal bleeding, right? Suppose if the estrogen is not there in the body, so the progesterone alone cannot produce a withdrawal bleeding because uterus is not primed. So that is the basis of this test. So suppose if the withdrawal bleeding is present, we call it as a positive progesterone challenge. It tells you the presence of estrogen. Estrogen is present in the body, but the patient is not having progesterone. But the patient is not having progesterone, which means only when you give exogenous progesterone, it is causing withdrawal bleeding, but naturally they are not secreting progesterone. Very commonly, you are talking about a peripheral anovulation. You are talking about a peripheral anovulation, and the most common cause of this peripheral anovulation is PCOS. That's what the idea is. Suppose if the withdrawal bleeding is not there. In this state, there are 2 possibilities. This is called a negative progesterone challenge. So there are 2 possibilities are there. The first possibility is estrogen is there, or probably even progesterone is there, but there is no bleeding because there is some uterine cause, which means the cause is in the uterus. Estrogen is there, but there is some uterine cause, like uterine adhesions causing Asherman syndrome, or probably a cervical stenosis where estrogen is there, progesterone would have primed the endometrium, and the withdrawal would have caused the bleeding, but the bleeding is not coming outside because of the uterine adhesions or cervical stenosis. So example is Asherman syndrome. And second possibility is estrogen is not there. Estrogen is very, very low in the body. Because the estrogen is low, the progesterone cannot cause secretory changes because uterus is not primed with estrogen. So withdrawal of progesterone will not cause bleeding. So this is the answer. So based on this only you are going to do the testing. So now, if the progesterone challenge is positive, which means obviously I know it's a PCOS, which means here estrogen is there. In PCOS, estrogen is there. I have told you the pathophysiology in detail. Estrogen is there, but progesterone is not there because of anovulation, and giving a progesterone and stopping it causes withdrawal bleeding. And if progesterone challenge is negative, then it gives a variety of conditions. For example, you have to think about uterine causes versus a real absence of estrogen. So in this condition, we do another testing called estrogen progesterone challenge. Now we have to do this test. Now whether this produces bleeding or not, if estrogen progesterone challenge is positive or estrogen progesterone challenge is negative. So what is the basis and rationale of this estrogen progesterone challenge? Suppose if the body has low estrogen, now what you are doing is your body is having low estrogen, so you are giving a estrogen. So the estrogen should prime the endometrium. So now you are giving progesterone, now you are adding progesterone to the regime. Now once you have added the progesterone, now the endometrium will become secretory. Now, once you stop the drug, it should produce withdrawal bleeding. Secretory endometrium, once you stop the drugs, withdraw the progesterone, it should produce withdrawal bleeding. Which means in patients who are not having estrogen in their body, this estrogen progesterone testing should result in, this estrogen progesterone challenge testing should result in bleeding. Obviously, if the true cause is absence of estrogen. So how will you do the test? You generally take this 3 weeks mark. So in the 3 weeks, you split into 2 weeks and 1 week. So for the full 3 weeks, I'll be giving estrogen in the form of ethinyl estradiol or conjugate estrogen, even though ethinyl estradiol is preferred. The last 1 week, I'll be giving some progesterone. After that, I will stop the drugs, which should produce withdrawal bleeding if the problem is low estrogen. Suppose if the patient is having Asherman syndrome or any uterine or cervical stenosis like cause, the withdrawal bleeding will happen, but it will not come out again. So that is the reason why if the estrogen progesterone challenge is negative, I'll be thinking about uterine causes like Asherman syndrome. Asherman syndrome, we know, isn't it? It happens usually due to probably a vigorous dilation curettage, where if you scrape off the basal layer, it can form adhesions. Or probably patients who are having damage to the uterus, and probably some patients who are having a severe pelvic inflammatory disease or a tuberculosis causing adhesions. So that can also result in Asherman syndrome. And conditions like cervical stenosis can happen after cone biopsy or after some procedures and surgeries. You can go for cervical stenosis. In these conditions, you can result in negative estrogen progesterone challenge. Usually in exam, it goes towards the Asherman syndrome. Usual reason is vigorous dilation curettage causing uterine adhesions due to scraping of the basal layer of the endometrium. So if the estrogen progesterone challenge is positive, which means the patient is bleeding. With estrogen progesterone challenge means it clearly tells you your estrogen levels in the body is low. That's the reason the patient is not having cycles. So this low estrogen might be due to, this is also an ovulation cause only. If the low estrogen is there, you have to think about whether it's a hypogonadotropic hypogonadism, or it could be a hypergonadotropic hypogonadism. So when you call a hypogonadotropic hypogonadism based on the FSH levels. If FSH levels are low, we think about hypogonadotropic hypogonadism. If FSH levels are high, we think about hypergonadotropic hypogonadism. So here the problem is very simple. Problem must be in the ovaries. Usual exam diagnosis will be premature ovarian failure, which happens in certain females, or hypogonadotropic hypogonadism, where the problem must be either in the pituitary or either in the hypothalamus. It's very difficult to differentiate these causes, even though there are certain investigations that can help you. For example, if prolactin is elevated, which is a very common thing in a female, it could be idiopathic or it could be adenoma, or it could be hyperplasia. So anything that produces high prolactin can produce this low FSH and hypogonadotropic hypogonadism. And it can be resultant of Sheehan syndrome also. You know, Sheehan syndrome is a postpartum pituitary necrosis. Remember, Sheehan syndrome patient usually will have a panhypopituitarism most of the times. Panhypopituitarism, they won't only have this low FSH, they will also be having a low prolactin, they will also be having a low TSH, and they will be having a lot of other hormones which will be very low, pituitary hormones. So Sheehan syndrome is a cause of panhypopituitarism. Clear? It's a postpartum pituitary necrosis. Hypothalamus causes are generally rare. In general, hypothalamic causes that are common in the pubertal age group is the hypothalamic amenorrhea. Hypothalamic amenorrhea. This is actually a functional cause. This is not a true hypothalamic problem. It's more of a functional cause only, where patients, especially these girls and ladies who are going for severe stress or weight changes, severe weight changes, it could be rapid weight loss or rapid weight gain in the form of severe obesity, can develop this hypothalamic amenorrhea, and they can develop anovulation. Clear? So reason for that is not so clear, but this weight loss has been hypothesized, and this weight loss has been analyzed very extensively in the research, and they have clearly proved that you need something called a critical body weight. You need something called a critical body weight to produce menstrual cycles. because like a woman cannot be fertile if she doesn't reach a critical body weight, and if she becomes fertile without a critical body weight, it's a evolutionary principle again. If the patient is very small and did not achieve the critical body weight, that particular female cannot tolerate the pregnancy and they are not fit for pregnancy, and this is an evolutionary principle, and probably that is the reason why puberty happens once you reach a critical body weight. That is also the reason why childhood obesity is associated with the early menarche, clear, early menstrual cycles. Whereas if you are very lean, it might take long time for you to achieve menstrual cycle. So these are some of the theories that have been told, and that is also one of the reasons why people with anorexia nervosa who have a rapid weight loss, once they go below that critical weight, they will not menstruate and their FSH will be low, and FSH can be normal. Remember, FSH is not only low in this case, FSH can be normal also. Even in the normal FSH, if the estrogens are low and the patient is having hypogonadotropic hypogonadism, then I'll be taking this normal FSH as low FSH only, because that's how endocrine principle works. The presence of low estrogen, even a normal FSH is considered to be low only. It works like a feedback, that's why. So these are the conditions that produces hypothalamic amenorrhea, clear? So depending on the condition, you can treat. For both hypothalamic as well as pituitary causes can be produced by some rare diseases like infiltrating conditions like some tumors, sarcoidosis, then tuberculosis, very rare conditions, but still they can, you have to think these things in mind. So that is the reason why you have to do a MRI of the pituitary whenever you think about a hypogonadotropic hypogonadism, which is a must. So most of these conditions will be picked up in the routine soup itself, because we have done TSH. If it's high, think about hypothyroidism, primary hypothyroidism related amenorrhea. If it's low, then you can think about Sheehan syndrome. Prolactin, if it's high, think about a pituitary adenoma or hyperprolactinemia. Low, think about a Sheehan syndrome. Total testosterone tells hyperandrogenism. 17-hydroxyprogesterone tells about your 20-hydroxylase deficiency, which produces hyperandrogenism. So these are some of the soup of investigation that you do, and it will be picked up in the early stage itself. So the most important thing here is to understand about the progesterone challenge and the estrogen progesterone challenge, which forms a very important part of evaluation and a cheap form of evaluation, and very easy to do in a female with cost effectiveness. That's why examiners are most oriented towards asking this progesterone challenge and estrogen progesterone challenge. I think we have covered as much as possible with regards to the hyperandrogenism and secondary amenorrhea. With this, I think we can close down the particular topic. In the next topic, we'll be moving on to the Cushing syndrome.